every clinical trial obviously is designed to mimic the patient population we see in the clinics. But I think we have to keep in mind that the patient population that enters a clinical trial is a little bit different than some of the patients we might see in our offices. I think if you look at the presentation of the case, a 72-year-old, heavy smoking history, some hypertension, hyperlipidemia, but otherwise fully functional, with considerable weight loss, 17-pound weight loss. I think I have to say that the patient probably mimics very closely the cohort of patients that entered the Pacific study. So from a patient characteristics, obviously, when you look at the case that's not in front of you and just read about it, it appears to be very close to the patient population that entered the Pacific trial. So I don't think I have any issue with this particular patient being treated as per the Pacific study. So I think I'm very comfortable using that data as it applies to this patient. So let's review what the Pacific really does represent, right? This is a very well-conducted international study. A large number of patients participated, randomized to standard of care, which is concurrent chemo-RT, followed basically by observation, versus concurrent chemo-RT followed by 1 year of durvalumab given once every other week. And the results are, again, as we're going to be discussing shortly. So the duration of therapy, as far as I'm concerned, is dictated by the results of the study. We obtained the best PFS and overall survival data in Pacific for patients who followed the protocol as written. So if my patients can actually tolerate the regimen without side effects or toxicities, then my preference is to use the durvalumab exactly as they did in the Pacific study, use it every other week for a duration of a year. And simply because I really don't have any additional data as to whether the continued treatment is efficacious or more toxic or not. So I try to use it for a year. Infections are completely different. Obviously, infections require active antibiotic therapy, depending on how sick the individual is, maybe hospitalization. So I think we have standard guidelines for management of infections. Infusion reactions, again, I haven't seen a lot of infusion reactions with durvalumab so far, but again, we have institutional guidelines for management of infusion reactions that go something as simple as perhaps some acetaminophen before the administration of the next drug to, this patient can never be exposed to this drug again just because they had such a severe infusion reaction. Most of the biologics that we use, antibodies that we use for the management of patients with oncologic issues can potentially lead to infusion reactions. Obviously, we get infusion reactions to agents like paclitaxel, sort of allergic reactions like that. So the management is sort of guided by institutional guidelines. Again, if the patient is severely symptomatic, fluids, H1 blockers, H2 blockers, all of those are sort of our standard armamentarium to use for somebody who's having a real either allergic reaction or infusion-related reactions.